All right, I'd like to try to get started on time. Since I have a bad reputation already, I'll be dictatorial. No. All right. So we're going to resume, and we have our regulatory session now. EHR certification and other regulations, what exists and what is missing. So we are really fortunate to have somebody from the Office of the National Coordinator with us. We have Rachel Nelson, who's a branch chief for policy analysis and implementation in the Regulatory Affairs Division of the Office of the National Coordinator for Health Information Technology. And we also have Ross Capel, who may not agree with everything that Rachel says. He is at the University of Pennsylvania, professor of biomedical informatics, the State University of New York, SUNY at Buffalo as well. And I am looking forward to this panel. So, Rachel, are you going to be here or there? Or?
Why don't you come up? I'll come up there. I will confess I meant to catch you at the break and make sure that I am in fact speaking first. So
yes, the answer is yes.
Happy to speak first. So first of all, thank you all for giving me the opportunity to speak today. As a federal employee, I'm going to give you the standard disclaimer. Any views or opinions that I might express during the delivery of this presentation or within the presentation itself are my own. They do not necessarily reflect a position or opinion of the Department of Health and Human Services or any of its components. Brief agenda, I thought I would start with a little contextualization of health IT certification and the regulations that ONC is authorized to promulgate and enforce within this complex socio-technical environment that others have spoken about, starting with Dr. Sittig this morning. Then touch very briefly on the existing 2015 edition certification criteria. Mention that there was in 2016, we finalized an enhanced oversight and accountability rule. And then something that changed this presentation a little bit from what it might have been had our timing been a little different. But earlier, you heard that the 21st Century Cures Act called on us to do rulemaking. That proposed rule is on the street right now, and the comment period is open, which I will come back to later. So this is extremely oversimplified. In order to get to three pillars, yes. So basically just to call out, which I like to do when I speak about certification and safety. We do have a role to play. Regulation may have a role to play. But when you look at the three pillars of safe and effective care delivery or safe and effective health IT development and use, either way, you have the people, the technology, and the process. Some aspects of each of these items are more amenable to the type of legal regulation that I'm going to primarily focus on here today. It is extremely difficult, for example, as you already know, to legislate culture. That you'll notice is now, luckily, you can regulate a few things in getting closer to this sweet spot where it all works together, where the configuration of the system matches efficient workflows, and supports effective communication between the people who have to communicate and execute on these processes. You can regulate what knowledge and skills are required to be licensed to practice medicine or practice law. You can regulate things about hardware and software. And you can regulate your users so that if they pause for more than 90 seconds, they have to log in again. And hopefully I don't need this, but I wanted to have it handy just in case. Okay. So the 2015 edition certification criteria were adopted pursuant to ONC's legislative authority to adopt, well, the secretary delegated it to us, but adopt standards for health, relevant to health information technology, to adopt or establish certification criteria linked to recognizing or maintaining a program of voluntary certification of health IT. So we are looking at products that are not necessarily subject to, for example, FDA pre-clearance requirements like device software would be. And we don't have authority to do pre-market clearance. That's not how it was set up and designed. So it is a voluntary program. There are, as I think we are all aware, incentives linked to the use of technology that has been certified as opposed to any random thing that you want to use, as well as some additional certainty that if we have certified it, it should do what it's certified to do. There are 60 criteria in the 2015 edition as currently certified. We kind of shorthand them into 8 categories. I'm going to highlight a couple just by mention here. Clinical processes would include things like computerized physician order entry for labs, medications, diagnostic imaging. And it would also include things like clinical decision support, maintaining a problem list, maintaining an implantable device list. The health IT design and performance category is another one that includes a couple of particular interests to today's topic, such as the safety enhanced design and quality management system criteria. Those are attestation requirements. They relate, I may be using the wrong program terminology for one of them, but these actually do not say, this is the safety enhanced design process you must follow. It says you should use one, and you need to tell us what it was. And quality management system, likewise, you need to have one and you need to tell us what it was. So that is what is in there now. There are a few other categories, but in the interest of time, I'm going to skip over it. And that leads me to a digression. There are a lot of slides in this deck that we may not talk about today. They will be available one way or one place or 3. Most of them are drawn from slide decks that are available from the healthit.gov website. And in fact, many of them are available from the slide decks related to our current proposed rule at healthit.gov/NPRM. And now, after 2015 edition was finalized, we engaged in another rulemaking that established in regulation a framework for our direct review of certified health IT in certain cases. Certain circumstances would potentially trigger direct review. And those listed in the regulation are unsafe conditions. So if we have a reasonable belief that certified health IT may be or is causing or contributing to conditions that present a serious risk to public health or safety, that would be a place where we might need to go in and direct directly review the certified technology's performance to see if it is in fact meeting all of the program's requirements, the certification criteria and associated requirements that it operate as it claims to. And the other circumstance would be impediments to ONC authorized certification body oversight. I can talk more offline if anyone wants to know more about the relationship of testing labs and certification bodies. But suffice to say, we authorize bodies that meet specific standards to actually issue certifications under our program. ONC does not directly issue the certificate to a product. But if there is a reasonable belief that certified health IT may be non-conformant with program requirements, but for one reason or another, it may be difficult for authorized certification bodies to assess that. One example we give is if it appears to be an interaction of two different products that are certified by two different bodies, it could be a little bit of a coordination issue. We also, in that rule, establish processes for more direct oversight of the testing laboratories, and we require ONC-approved certification bodies to post identifiable surveillance results on the certified health IT products list on a quarterly basis. So if they go out and they do surveillance, whether it's randomized or in response to a complaint submitted on a product, the results of that are now required to be posted in an identifiable way so you can see they surveilled a product and this is what they found. And now we come to what's going to be taking up probably the majority of time here. I've selected some features to talk about out of our 724 manuscript pages. It's less than that in the Federal Register because it's smaller print and squeezed out. And the citation is up there, 84 Federal Register, starts on page 7424. My rulemaking process disclaimer, and I apologize to those of you for whom this is extremely repetitive, but I feel obligated to say ONC must protect the rulemaking process. We have to comply with the Administrative Procedures Act. So we can only present information that is in the NPRM as it is presented in the NPRM. If I misspeak and say result instead of respond, that's not an interpretation, that's just a slip of the tongue. ONC cannot interpret that information nor clarify or provide further guidance. And also, this is the point I probably alluded to earlier. I want to encourage everyone in this room that is interested in these topics, for whom I think some of these proposed policies will be of extreme interest and do intersect with things that you work on and think about on a regular basis. I want to encourage everyone here to review the rule and share your thoughts with us. All feedback. Tell us what you think is really expect to work really well. What do you think could be improved? Is there something that you think is less positive? But please give us feedback. Also, I'm happy to speak about various topics offline, but I want everyone to be aware that ONC cannot address any comment on suggestion or statement made by anyone in this presentation or in any other informal venue outside of the public comment submission process in that rulemaking process. So if you want to be sure that it's in that rulemaking docket and is addressed within the rulemaking, please go online, go to regulations.gov and submit it before the comments close. They are scheduled to close at 11:59 p.m. on May 3rd for electronic submission. And you can easily find our docket by going to healthit.gov/NPRM and clicking the link to the comment process. The purpose of the rule was, the purposes that we like to highlight are to increase innovation and competition, reduce burden and advance interoperability, and promote patient access to their information, and hopefully all of their electronic information structured or unstructured at no cost. And for those of you who may not speak geek every day, the notes fields and the narratives that we've been talking about this morning are unstructured, and structured is the result of clicking little drop-down boxes. That's my very non-technical way of explaining that. I'm sure others in the room have better ways to explain that. We are taking deregulatory actions, such as removing the requirement for randomized surveillance of certified products in the field. We had feedback from stakeholders, including healthcare providers, that they did not feel the time burden and the effort they were putting into that process was giving them back what it was worth. So we have proposed that as to remove the randomized surveillance requirements. Certification bodies would still be free to do randomized surveillance, but no longer required. We are proposing to remove the 2014 edition, the obsolete edition, from the Code of Federal Regulations to just reduce the risks of error that come with inconsistent implementations and use of inconsistent versions of the technology. We are proposing to remove the ONC approved accreditor from the ONC Health IT certification program. That's an extremely technical procedural issue related to how a certification body gets approved or authorized. If you want to know more about that, please talk to me offline. Removal of certain 2015 edition certification criteria and standards. Those are proposed. And there's a slide that shows them better later on. Also, removal of certain certification program requirements. Those are related to what the certification bodies are required to do and what developers may be required to disclose, some of which may be obsolete in view of the requirements as a result of implementing the the CARES Act. And we also propose to recognize the Food and Drug Administration software pre-certification program when it is finalized. So if you have it, or we also solicit comments if we should consider setting up a parallel independent process if folks feel that maybe the FDA pre-certification for some reason is, they don't, in their view, not ideal for our purposes. And what that would do would be streamline certain certification processes under our program for developers who achieved and maintained health IT pre-certification from FDA. And there's a lot more detail on updates to the 2015 edition criteria. That's a slightly larger slide on the criteria that we're proposing to remove. Specifically, there's also a replacement. There was an old data export requirement. It is proposed to be replaced by what we're calling electronic health information export, which requires that the user be able to export a patient's entire record, all of the information that the software maintains, without special intervention and assistance from the developer. So the doctor's office could just push a button and run a patient's entire record and enough documentation on the non-standardized data within it that someone would potentially know how to deal with it, how to process it on the other side. And we are also proposing to replace something we called application access data category request and application access all data request. The standardized API for patients and population services is, as was mentioned earlier. That's one of the revisions that might also be of interest here, because that is one of the ways we would free up data to follow the patient where they go and where they would send it where they would like to go. And in the interest of time, because I'm inside the 5 minute, I'm down to 1. I'm actually just going to leave on a plug, I think, for the EHI export criterion, and a reminder that all of the information blocking provisions are in the proposed rule. And if anyone is intrigued by their potential interaction with areas of interest to you, please do review them in the rule and share your thoughts with us through the comments process. Thank you.
Yeah. We tested it a minute ago. It worked perfectly. Of course, now it won't. But I muted it. My God, it worked. Hi. So after this morning, I think I'm going to have to relinquish my role as the most vociferous critic of EHRs, because I've been joined by my colleagues. So I was asked to present something about which I've never actually presented before, which is certification, and it's a good opportunity. So there's a special place in hell for people who read slides to literate audiences. So I've been known to do almost entirely silent presentations. But the important thing about medical error is that its medication error is the largest by far, and prescribing error is the largest proportion of that. And after 3 hours this morning, you guys know most of these terms, so we'll go. It's interesting. CDS override rates are as high as 98 to 99%, which people may not realize. So something happened in 1997. The EHR vendors and enthusiasts went to the FDA and they said, don't regulate us because we're a baby, you don't want to stifle, and we got to get everybody to buy them now. And they won. So since 1997, the FDA has said basically, we're hands off. This is an infant industry and we're not going to touch it. Success. But how infant? So EHRs are about 50 years old. So are jet planes. Should we not regulate them? You know? And what's happened since 97? Well, of course, in 2004, we created the ONC. And if you're familiar with the people involved with that, the ONC and the laws for high-tech, rather, actually came from plans that had been developed 30 years before by the industry and by enthusiasts. And now, of course, we have the new 21st, and correct me if I'm wrong about this, Rachel, but I just learned that the new law prohibits the FDA from any oversight of EHRs, except for CDS. That's what Doug Frisner. So what happened in 1997 is now baby steps to the regulatory-free Wild West zone that we have. And why would that happen? Well, you're a bunch of lawyers. Damn it, Bismarck did not say that. And of course, with regulation comes regulatory capture. And so the plans that had been in fact. So here's something that you may not know. There was a very, very influential article done in New England Journal of Medicine just at the start of this process. And they sent a survey to hospitals saying, what do you want in an EHR? And the hospital said, we want more money, we want incentives, and then reasonable things like tech support, evaluation. But remember, my original PhD was in sociology, and I've been teaching research methods for 45 years. They did not ask any of the questions that really were relevant. Nothing about usability, patient safety, interoperability, data standards, and the like. Fascinating. So they found what they were looking for. I don't suggest it was ill intent. I just think that's what they were focused on. So in 2008, I wrote a JAMA article on two clauses in EHR contracts. The first was the hold harmless clause, which says that the vendor simply creates a tool used by a learned intermediary. They are not responsible for anything. So even if the vendor has been informed 1,000 times that this particular screen causes medication error by converting kids' weights to kilograms and not telling people, or going from kilograms to pounds, causing doctors to double dose and kill babies, and there have been 1,000 complaints about it, the vendor is held harmless, that clause. The other one is the non-disclosure clause, which prohibits you from taking a screenshot. You're a doctor, you're seeing this thing, screenshot is horribly confusing, dangerous, getting a lot of nods here. You can't take that shot and send it to your colleagues, say, guys, look out for this. That's stunning. So, 2 IOM reports and the AMIA task force. And I just noticed Don Rucker was a member of that, along with me, on this task force. Those IOM reports and that task force called those clauses unethical. So what's happened since? Well, I haven't seen anything to force people. And in terms of certification, I'm still not aware of any law that, or non, has that been prohibited, those clauses? No.
I don't believe so.
So, history of certification, and you guys have done this already. So originally it was done by a group called CCHIT that was actually a vendor trade group, and everybody passed. It was just, in fact, they all passed with flying colors. It was just stunning. And this is what the ONCU inherited when they started. And then, just as we learned, in 2015, the ONC set up its own certification process, which was seemingly far more rational. So just a few approved testing organizations, actual criteria that could be seen, although the vendors had the bar lowered 3 or 4 times to levels of functionality that they said they achieved 20 years ago. Okay. I evaluated some evaluation sessions where a doctor had to change a schedule from twice a day to once a day. It took 4 hours and 7 engineers. A doctor ordinarily would have half a second for that. It passed. No time. And there were 3 testers, and so if you didn't like the results from one, you just judge shop, an interesting term there. I found one failure. Pause. That iron is a few feet from here at the Cleveland Art Institute. It's man-raised dadaistic iron. I did not know that before going over. So what's most hated about them? Please read that. That's a quote from a forthcoming article, not by me. And Bob Wachter, you're Bob Wachter from UCSF. So here are some examples. A drop-down menu that continues 4 screens down and doesn't warn the young doctor to keep on clicking. So they pick the test that makes the most sense from the screen available to them. Not a good idea. This is how to pick an anticoagulant to stop, anti-anticoagulant, to stop somebody from bleeding to death. And this is your chart for immediate selection. So there's an article in next month's JAMIA that says, guys, you know, we don't even have a standard for how to record names. I mean, talk about complex medical things. We can't. My university, University of Pennsylvania, has 32 ways of recording a patient's name. Coppell Ross, Ross Coppell Ross, J Coppell, goes, Jones. So even the simplest stuff. And then this is one of my favorite charts. This is 40 ways of recording blood pressure. So these 3 make entire sense. After that, it's Alice in Wonderland. This is because the computer programmer did it alphabetically, so the word diastolic comes before systolic 4 screens later. Doctors actually want to see those numbers together. And then lack of interoperability. So Karen DeSalvo issued the ONC roadmap to interoperability about 4 years ago, 5 years ago. And at the time I said it was 20 years too late, and it was a 10-year roadmap, and I said should be 6 months. It's taken a while. This is an article from this last year saying, come on guys, get this together. I didn't mean to do that. So what are the most hated aspects and what is missing in certification? And all of those have profound patient safety. I mean, this is how we kill patients or harm them and piss off doctors. Now, the ONC now has adopted this, and that's wonderful, and I'm very proud and pleased. But why has it taken so long? Regulatory capture. So a couple of years ago, I was asked to testify on usability, and the vendors and the ONC gave me a bunch of questions. And here were the questions. Is it not the case that usability is entirely subjective? Unmeasurable. I like the contradiction in that one. In other words, it's the individual doctor's fault, not the system. And there is some truth. I mean, implementation is a multi-billion-dollar event that takes 3 or 4 years, and there's ample room for screw-up. But if you know anything about usability, this is nonsense. Usability is certainly a more exact science than medicine. Now, there have a hell of a lot fewer variables to deal with. And, you know, software is written by humans, whereas humans are the result of chaotic evolution for a few billion years. So it should be easier, but you can see the point. So what's the result? And here's my sort of solutions. the ONC was focused almost entirely on selling EHRs. Even Farzad said, if everybody would buy an EHR, all of our problems would be solved. Now we have an installed base of, Farzad was chair of the ONC a while ago. Farzad Mustashari. So, you want me to do something? Prohibit those laws. Should I send that into the 21st, into the...
Well, all comments are welcome. Those that are out of scope, we may not be able to act on in finalizing this regulation. I do want to point out that the gag clauses, otherwise nicely known as non-disclosure, would come out as a condition of certification pursuant to the Cures Act.
My 2008 article exposing them. 11 years, what the hell. Yeah, so in closing, within the time, you cannot combine data that have 57 different ways of recording the simplest information and somehow hope to pull that together. It's chaos. And I mean, this is what we wanted, right? What did we hear earlier? And for God's sakes, EHRs are now the most hated aspects of medical practice, of which CDS is the most hated of all EHR. We know so much about usability, and yet it's been cast aside for so much. Penultimate slide. Certification is an absolutely perfect opportunity to sort of make the improvements that we all know we need. And we just need to avoid enshrining existing vendors in their power. And I thank you.
So I'm going to take advantage, unless Sharona has an announcement, of asking questions. To ask a first question.
Well, I just wanted to remind everyone that in your blue folders there is a sheet that tells you how you access the written material. The saved trees, it's all electronic, but we have a website that contains the slides and some articles that we put together for CLE purposes, so please look at this sheet. All right, next.
So I am homo pre-digitalis, if you can imagine. When I started teaching, we were getting our first computers. And the problems you're describing, in my experience, are clearly not just those of EHRs. They are those of many, many computer applications, particularly those that are being used by homo pre-digitalis and other people who are not very computer savvy. And so, for example, the example you gave of the screen that doesn't go far enough down, if anybody at this university has ever tried to use Sparta, which is our grant funding software, it's insane. With all due respect to whoever programmed that, it's crazy. And the only thing I can assume is that they don't beta test it in idiots like me. Or doctors, who actually have to use it. So my question is that true? I mean, it's not rocket science. Try it out on the least savvy people that are going to have to make life or death decisions on this, and then fix it. What's the problem?
Okay, so they do test it with doctors. They have many doctors who are employed by them, and they test it. But there are several factors. One, there's a certain amount of co-optation. So the doctors start working for the vendors and they start out being dedicated surgeons or whatever. And within 5 months they go, look, Ross, there's limited real estate. We've got 400 different implementations, and we have to satisfy all of these customers and blah, blah. So they make marketing decisions. And also, the changes are very complex. You know, Dean earlier talked about the number of devices connected to the EHR. I did a little survey, and I asked CMIOs, how many IT systems are connected to your EHR? And the minimum was 150. And the max, some schmuck said 800. He counted every smart pump or something. But the point is, many of those devices then connect with each other before they connect. So it's conceptually, 150 squared. They are terribly complex systems. They are held together often with duct tape and chewing gum from all of the different systems that have gone into them. And so it's terribly complex. If you call up a vendor and say, I've got this problem, your problem will go on a list that's about 4,000 lines long, minimum. My university, I got the list of requests for repairs and the like. It's 10,000 lines long. Now, some of them we can fix. Some of them are just so complex. Some of them the vendor makes you buy a build, which they then own. Look, they are very, very, as everybody said before me, they are very complex pieces of software with literally millions upon millions of lines of code. And it's very tough. They're not done to piss off doctors, but their first commitment is to sales and CFOs and the like, not to clinicians who are just users, like drug addicts or something,
Well, I'm just going to say...
Did I?
Well, I do think that we encourage the use of safety enhanced design and user centered design, which, if you take our guidance to heart, you would be taking a sampling of actual end users and trying to pull them into beta testing. We don't absolutely mandate. We don't say you've got to go out and sample. And one thing that, stepping out of my ONC role, having worked on development of various systems for various programs before I came to ONC, I have noticed that if you solicit for volunteer beta testers, you will tend to get the most enthusiastic digital supporters that are available and not get the folks who use the computers because they need to.
No, you have to do a test, and the only people who are allowed to beta test are people who fail the test, and it's a real simple computer test. I mean, 747s are very complex machines, and with the exception of the 737 MAX, I mean, we don't have plane crashes anymore. How did the FAA solve that?
So while we're... Oh, you have a
So to address Max as well, so in my role in my organization as a physician informaticist, I take part in usability testing both in WebEx form and in Verona at Epic, right? But that's because I'm walking through the halls of Epic and I'm walking past the usability room. And if I tried to get one of my colleagues to take part in usability testing that was homo pre-digitalis, that fights tooth and nail to use the system in its current state on a day-to-day basis, it's going to be quite the battle in order to try to get them to use something in a future state or some kind of something that we're trying to implement in an upgrade. And so I 100% agree with your thought that it's the people that have already bought into the system that are going to be taking part in this as a rule.
I was going to say that I applaud the ONC for requiring the safety enhanced design, but if anyone wants to go onto that Chapel website, you can review the safety enhanced design reports from the EHR vendors. And all they did was require you to do it. They didn't require you to fix the problems. And so when you read about those things, in most of those reports, several of the reports show that less than half the people could accomplish the tasks in the test. And so so you make a rule that says you have to do safety enhanced design, did safety enhanced design, submitted to customers, product not changed as a result of safety enhanced design. And that's what it's hard to figure out how much you can regulate and how much you can change. And people have said maybe we should just have one EHR that's really good. We had one of those, it was free. The VA decided to throw that away and buy another one for $10 billion. So,
well, 20 billion, but who's counting?
Yeah, they haven't admitted the next 10 billion yet.
Yeah. Just what some of it is, there's no room for buyer's remorse. So my university is spending about $1.8 billion on our Epic implementation. We're giving $500 million to Epic, and the rest is our own implementation and training and retrofitting costs. What? Lost revenue. Harvard, where I've worked for many years, is spending about $1.9 billion on their Epic implementation. It's the same $500 million to Epic, and then I think they hired Accenture or Deloitte for $600 million to help with, and the rest is their own implementation. And then there are order set wars where doctors sit around beautiful tables with high fiber muffins, fight out the number of milligrams per kilogram for patients under whatever. And that all is money. But if you spend $2 billion and 5 years setting up your EHR, there is no room for buyer's remorse. If I buy a toaster and my wife says I hate the thing, to preserve domestic tranquility, I'll blow the $30 and get another toaster. You don't do that with a $2 billion event. I mean, you are married to the mob.
So Epic is the mob. Okay.
I didn't say
just
that.
noting that down.
Epic.
Okay. No, just trying to take some notes here.
That Epic tried to fire me and Chris Lehman twice.
Oh, the fact that they haven't killed you as well. Anyway, another conversation for another time. So I'm intrigued with the carve out of the information blocking applied to evaluating EHRs that the FDA is now going to be let loose on at least clinical decision support functions. Do they have the architecture for that? Or are they going to be building it from scratch as far as you know? That's question one. And then question two is for Rachel. In the oversight functions that ONC is being given, do they have sanction powers for those who fail?
First,
Well, I'm not aware of a hell of a lot of information blocking. I think it's like worrying about ghosts.
Skip to the can the FDA do something serious about clinical decision support?
Yes, they have that authority. Whether they'll do anything, I don't know. I mean, it's absolutely detested by most clinicians because a lot of the CDS alerts come from a study of wolfbane done in 1842 in Lancet, and the lawyers say leave it in because there was an adverse reaction in London. We do try to titrate them and cut them out. I don't know what the FDA will do about them. Nobody wants them to be annoying. On the other hand, they're brilliant ideas, and if they didn't exist, we desperately want them to exist.
Yeah, the one thing that struck me when Ross was speaking was some aspects. There's regulation of the clinical decision support, which is the technical implementation of the clinical guidelines, and then there's the underlying clinical guidelines. And there may be some work that can be done by various stakeholders other than the IT people, to make something that is easier for them to execute in a way that is accurate and quenchable, so it doesn't just keep going off if you told it, no, that doesn't apply to this patient. So that is just one sort of thing. Like if the clinical folks would agree that we no longer want to start, that wolfsbane thing is no longer relevant, and maybe that could go away. When it comes to enforcement abilities in the CARES Act, the responsibility for investigating and taking enforcement actions against information blocking is designated to the HHS Office of the Inspector General. Within the ONC program, it is a voluntary certification program. Non-conformance or non-compliance with requirements to be certified, we can decertify it. It's what we have, and the CARES Act does designate that for healthcare providers found to be information blocking, the OIG would refer them to appropriate programmatic offices for determination of disincentives.
Thank you. So, Rachel, this new proposed rule, in what ways does it, if any, does it improve usability or make EHRs safer, more usable? It sounds like the Cures Act actually did something very good, which is remove or make these gag provisions illegal. So that's a huge step. What does the new rule do by way of patient safety?
Well, I want to clarify for the lawyers in the room that the Cures Act did not actually outlaw all appearances of gag clauses in IT vendor contracts. What it did was authorize that as a condition of certification, if you want your product certified, you cannot have gag clauses in your contracts. For the lawyers in the room, that's a distinction that has some meaning. Some of the things that the Cures Act put in as conditions of certification and maintenance of certification, I think removing the gag clauses is potentially significant because it means that you can communicate about your usability concerns, your safety concerns, to ECRI, to other patient safety organizations, and you're not violating the contract. The one limitation, since we're having this conversation, the one limitation I want to point out, because it does come up in some discussions of state adverse event reporting systems, if the vendor may not be allowed to preclude you from talking to anyone you want to about your concerns. If you're employed by a hospital or health system, they may institute internal organizational policies that say only talk to our safety team. Do not. You are not the one to take this public. We will decide when to do that.
Ouch.
But
how do we learn except from finding problems and fixing them? I mean, the ONC has for years argued that and literally they put advertisements saying, we want happy stories about how wonderful your EHR is. And that at no point did they say, send us any problems. Now, they're
Health
better.
IT feedback. HealthIT.gov, look for Health IT feedback.
Yeah.
Send us whatever complaint you feel the need to.
No, the ONC has changed its tune, and they are much more enlightened now. But for years, it was just sales of EHRs. And the result is that they're wonderful. I agree with Dean when he said, they're dramatically better than paper. There's no comparison. But they're also better than wet cuneiform tablets and semaphores and smoke signals and God knows what else. But they are magnificent. But they are nowhere as good as they could be and should be. And the result is that we harm patients a lot, and we frustrate the hell out of doctors. When doctors are quitting, the lead thing they say is, I can't take the EHR.
Yeah, I was going to say we should always remember, like you said, why don't they come and test it with the doctors? I didn't want to say that, but the EHR wasn't made for the doctors. It's a billing system and an inventory management system for a hospital. It just happens that we've decided that the doctors should be the users of that system. That was a decision that we made and then the ONC enforced, but that doesn't have to be that way. And so many hospitals, like I worked at a hospital that started building electronic health records over 50 years ago, and they had to get rid of their homegrown system, which worked fine because they didn't have physician order entry because they thought that was a bad thing to do. And so when the ONC required that physicians enter the orders into the computer, they had to buy another system because they couldn't do that in their system. And so we get into a funny place where we think these systems are for doctors because those are the people that use them, but the people that buy them are the hospital executives and the finance people so that they can do billing and manage their hospital.
Okay. I have a question from the patient's perspective. From the patient's perspective, when you move from one community to another, your current medical doctor cannot access the electronic records from the other institution. Is there anything in the Cures Act that's going to promote that usability?
Well, yes, so I think there's a couple different things that I would expect would start to make that easier. One is the application programming interface standards, which would, at least initially, require that the patient at least what we call the U.S. core data set for interoperability information from that patient's record would be available through an application programming interface that your new doctor could connect to, potentially point to point, but also potentially through a trusted health information network. The other, I alluded to the proposed new criterion for total EHI export, which would require that your old doctor's EHR be able to output everything that it had on you in an electronic computer processable form that could then be taken, transferred in some appropriate way that is reasonably secure to your new doctor or to a third party, the recipient of your choice as the patient. So that should make it a lot easier for your prior doctor to get everything out of the system without needing their vendor's assistance, and therefore it should make it easier for you to say, give me my whole record, or send my whole record to my new doctor.
Okay. Read and break.
Just one of the things that we miss with history is that, for example, back in 2005, 2006, a colleague and I were asked to do a systematic review of all leading market EHRs. At that time, we reviewed 25, and it was convenient for various reasons for us to hit another 3. And among those EHRs, we found that there was a significant gradation between those that did certain things very well, and what we were looking for was essentially a patient care-oriented representation of the current state of the record and the current state of the patient. And that subset that we identified at that time that performed that, and also we were both in the compliance mode and accomplished things like any information that was imported forward without a doctor's or nurse's cognitive act to affirm it was in a different color on the screen, and if it wasn't affirmed, it did not get included in the final record, which would completely obviate all this nonsense about well, a substantial fraction of copy-paste. The other thing was that when you affirmed something as valid, the attribution path to where it originally came from was also retained intact. Every EHR that did that back in 2005 is gone. So part of what has happened has been the opacity of the marketplace in terms of what works well for patients. And I think that's a really important point to understand the dynamics of where we are now. Yes, these were the ones that won the race were designed to be billing systems, but not all EHRs were. And the especially good ones had very vigorous feedback loops from their practicing clinicians. Hey, improve this, why don't you try that? And maybe this would work better. And they had a rigorous system for basically taking input from practicing clinicians with suggestions, running them through an analysis set, and implementing in trial those that the majority of their advisors said might be good, and then they became part of the product. So we shouldn't miss the fact that what we have now is an outcome of a system. It's not an incidental outcome. It's not an accidental or unexpected outcome. If you pay people to implement EHRs that do this many things, that's what you get. Period. Anyway, just that sort of informational point. And then I am intrigued with this notion of increasing oversight. So thank you for your comments on that, since we've run out of time.
Okay, so we are going to break for lunch. It is 45 minutes. We will come back at 12:45.